So you pick it up from your laboratory, but you also pick it up from someone on the front line who says, gosh, I think these two patients have a similar rash or something like that that's happening. Can you come help me out? And that's really where everyone's an infection preventionist. You need everyone in healthcare to think of themselves as being able to pick up the phone and wave that flag to say, can you come in and help me as the expert look into this further?
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
On this episode of Transmission Control, Larry and I are going to be speaking with Catherine Kroll, System Director of Infection Prevention at Peace Health. And she's quite an inspiring leader. We're going to have an excellent conversation today about navigating during one of the most difficult times in infection prevention, especially in healthcare during COVID times, and what that meant, especially during a staffing crisis. And how do you lead an organization that spans 3 different states? We're going to get into all of that today, Larry.
Yes, and I'm looking forward to talking with Catherine about some quality measures and how we can kind of judge the performance of a hospital, about recruiting preventionists, and maybe get into some issues about full disclosure of infections and whether a hospital discloses to its patients the cause of an infection, maybe the breach, the infection control lapse that occurred, that if there's full disclosure, patients are much more understanding and willing to cooperate with the hospital than maybe calling a plaintiff's attorney and causing trouble. So there's going to be a lot of fascinating things we'll be talking about today, and I'm really looking forward to it.
Stay with us. We're going to be right back with Catherine. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
We're speaking with Catherine Kroll, System Director for Infection Prevention at Peace Health. And this is a conversation that I've been anticipating for quite a while, Catherine. I know between the two of us getting sick in the fall, we had to push this one back a little bit, but very happy to have you on the show today. And we titled this one, Keep Up with the COVID Times. And while this whole conversation won't be strictly about COVID, there's some things that we learned during the pandemic that, especially with all the fluctuation, moving parts, changing guidance, you lead a pretty big infection prevention team, and that is a challenge to make sure that everybody, not only on the team, but everybody they speak with throughout the organization, all know what's going on or keeping up with the changes. So thanks so much for coming on the show today.
Yeah, I'm really excited to be here and to talk about how we at Peace Health kept up during the COVID times and the lessons that we're taking forward into the future, especially as it relates to being across 3 states with 3 different sets of guidance and federal guidance competing. It's going to be a great conversation.
Why don't you talk about your background? Because even as we were getting ready, Larry was asking you some questions about some potential topics for us to discuss. And you brought up your public health background. And that's not something that you and I had talked about. And that's something I didn't know about you, even though you and I had crossed paths for a number of years now. Can you talk about that? And how do you find yourself at Peace Health today?
Absolutely. Nobody is growing up and saying, I want to be an infection preventionist. Or maybe now they are because of the COVID pandemic. But infection prevention is one of those careers that you kind of stumble into. And that's certainly how I did it. I knew from a very young age that I wanted to be an epidemiologist. I actually, when I was a kid, I said I wanted to be either a detective, an FBI agent, or a doctor. And I'm an epidemiologist, which is a hybrid of all three of those. So I get to investigate the outbreaks, figure out where they're coming from, and stop it. And so I was not one of those kids who struggled with what am I going to do when I grow up. It was just how am I going to get there? And so I came into public health knowing that I wanted to do a master's in epidemiology and public health. I did a postgraduate fellowship with the Florida Epidemic Intelligence Service, which honestly is the best job that anyone could ever have. You would wake up in the morning and they'd say, here's the outbreak you're going to work on, or here's the problem that we need help solving. And you could be deployed all over the state of Florida to work on it. I could not speak highly enough about that fellowship experience, which really set me up then to go into local public health. And while I was working in the local public health sector, my 5-year-old niece ended up with cancer, and she got a C. difficile infection during that cancer treatment. And while we were chatting with the hospital about, well, how could this happen? A lot of it just seemed like, well, cancer kids get this. And my response was, well, I'm a trained microbiologist and epidemiologist. Cancer kids don't just spontaneously generate C. difficile. Somehow she got into it in her environment. And in looking around and talking to them about their protocols, I found that there was really a challenge with how they handled their toys on their cancer unit. And that's what brought me into knowing what infection prevention in the hospital was. Before that, I didn't truly understand what infection preventionists did.
It's funny you describe that scenario of just having the shared toys and who cleans that. And that even goes back to environmental services and how all that comes together in the healthcare setting. You said maybe because of COVID times, maybe more people want to get into infection prevention, but I feel like there's lots of other departments in the hospital that have gotten more attention in general as a result of the pandemic, whether they're related to infection prevention or not, like cleaning and sterilization and sterile processing. I feel like just the concepts that are related and intertwined with infection prevention have received raised visibility.
Oh, absolutely. I see that in our own organization, and I see that in talking to other directors. It's given us a chance to highlight the other careers in healthcare that are not doctor, nurse. You know, when you ask a kid what they want to be when they grow up and they talk about being a doctor or a nurse in healthcare, those are amazing careers, but there's so much support that goes around so that doctors and nurses can do the amazing work they do. And I think that COVID really gave us the opportunity to highlight that, the importance of having a clean environment, the importance of making sure that the instruments that you use are sterile and appropriately reprocessed. Looking at quality in healthcare and how do we measure if you're getting good quality, and how do we use lean concepts to quickly take and change things that aren't going well that we can see improvement for.
So, Catherine, I have a question for you, and the many questions I have for you today, and I appreciate your coming on our show today and discussing them with us. I wanted to, before we get too much further ahead, I wanted to ask you a question about that situation that you were saying with C. diff and identifying it maybe to a toy, for example. Can you talk a little bit about, we hear so many people getting C. diff infections when they go into hospitals, and yet if we look in the dockets, we don't see a whole lot of patients suing hospitals because of C. diff. Can you talk about whether is C. diff considered maybe an unavoidable infection that is covered or not covered by the informed consent? Because we need accountability, and the way we prevent these infections is by doing root cause analysis and determining what's really causing them. It seems every hospital is going to have patients, or maybe that's a little dramatic. Many hospitals are going to have patients coming down with C. diff. So are these all avoidable? Are none of these avoidable? Are they all considered unavoidable? What have you learned about your classic C. diff infection that would be presumably healthcare acquired?
Yeah, so certainly many C. difficile infections are avoidable, and they're avoidable by first preventing the person from getting colonized with the bacteria. And so that is your routine infection prevention, making sure that it is cleaned on surfaces. And C. difficile is harder to kill on surfaces because of the toxin that it has. So we have to think about what are we using to clean our surfaces? What are those high risk surfaces? Do we need to hit them with something that is maybe more caustic, but also better for the patient care environment? And so it's a risk benefit analysis. So the first thing is making sure that it doesn't get taken on hands or surfaces to the patient's mouth and get into their GI system that way. And then the second thing is making sure that we use antibiotics appropriately. Every C. difficile infection that we have in our hospital gets a review for appropriate stewardship. And it's challenging to make sure that the antibiotics you're using are the correct antibiotics. And does the patient really need antibiotics? So we're looking at all of those. Certainly you have some small subset of those infections that you look at and you say, darn, we did everything we could and we don't see anything that is available by retrospective review that we could have done to prevent this person from having a C. difficile incidence. But that's relatively rare. We almost always find opportunities for that. And we have a pretty intense review process in our hospital. I know not all healthcare systems have the resources to be able to do that review and plan, do, check, act, and change. And I just feel really fortunate that the system I work for makes sure that we're resourced to be able to do that ongoing work.
Is the informed consent process that patients sign then, does that generally acknowledge that there are certain infections such as a C. diff that might be unavoidable? That's just kind of the business of going to a hospital, and patients kind of understand that?
I don't think that anyone's informed consent says that there's an unavoidable infection involved. It's certainly a risk when you come into healthcare. Say, for instance, you're having surgical procedure and you're informed that surgical procedures have a risk for a surgical site infection. Here are all the things we need to do. We need your partnership on as a patient to help avoid that. And so I think that there is some onus on the patients in that case to keep their surgical site clean and to take any post-op antibiotics that they are prescribed if that's necessary, which is pretty rare, and to follow the surgeon's instructions. And with C. difficile, you also make a contract in terms of you need to be doing your hand hygiene as well. If you're a patient and you're going to eat, please wash your hands before you eat. We don't want you touching the hospital environment and then putting your hands in your mouth.
One thing that you said at the very beginning was nobody wakes up and says, oh, I want to be an infection preventionist in the hospital, except maybe they do now. But we also have this staffing crisis really in healthcare all across the board. But certainly infection prevention has not been able to dodge that struggle either. And it's interesting. The need for infection preventionists has grown for all the reasons you just mentioned. But not only is it now getting more resources, it's getting highlighted. And yet now it's where do we get the bodies? And the demand for the job has increased substantially at the same time. So when you start to look creatively at filling those positions, really two questions, because there's a lot of new people, and we're going to tie this to communication here in a second. Where do you find new people outside of the organization? What kind of backgrounds? And then where do you look within the organization? We talked about EVS and sterile processing, all these different areas that infection prevention touches. I'm assuming that at some point you start to look at those individuals who are high performers who might be able to operate outside of their silo and start to expand themselves throughout the organization the way that infection prevention needs to impact the entire organization.
Yeah, Justin, that's a great question. So I have two philosophies around that. Number one, always be recruiting. I am always recruiting and looking for people who are interested in infection prevention. we knew before the pandemic that we were headed into a crisis in infection prevention. We have a lot of folks who are older and are looking to retire that have been in infection prevention, and we're going to lose a significant amount of our workforce out of the infection prevention. So even before the pandemic, we knew that was coming. And so recruiting has been, as long as I've been an infection preventionist, recruiting has been high up on my docket, even before I was in leadership, because I knew that the field needed good folks coming in. And it's such an amazing field to be in. You don't know what your day-to-day looks like. You get to touch basically everything that happens in the hospital or in the ambulatory setting for healthcare. So it's a fantastic field. So I start with how do I find people? Well, I share my passion for what I do, and I look for non-traditional. So I think that the best infection prevention teams are ones that have players from all different backgrounds. Traditionally, infection preventionists have come from nursing, public health epidemiology, or lab background, and those are all incredibly important backgrounds. I have expanded that in our organization to also look for sterile processing, for people who have done non-traditional roles like leadership. Most of what we do in infection prevention, we can teach you the science, but I can't teach you the passion. So I look to find someone who wants to be in the work and who's passionate about it. Because if you're passionate, I can bring you to the table. I can get you to trainings. If you've got a basic science background, you'll come in and you'll be able to understand it. But I can't teach you to get in there and advocate for the patient if you're not willing to step up to the plate.
Yeah, I think that principle can apply to just about any career. And it's really a global recruiting technique. You are going to have a much easier time leading people who want to be led, who are craving to learn and make a difference, than you are trying to push somebody out there who's really more of a punch in, punch out. That is just such a fantastic point that I don't care where you're from listening to this podcast. You could take that one to the bank, not only as you move into leadership, but I like something you said at the beginning, even as you approach your day-to-day. If you want to surround yourself with great coworkers, you should be recruiting whether you are a manager or not, and finding those people that are passionate, because it will make your job easier just as a coworker, having more coworkers who feel the same way that you do. It's all about culture building. And speaking of culture building, one of the keys is communication. There's nothing worse than being an employee who feels like they're getting different messages that contradict each other on a regular basis. Now, here's the crux of it. Sometimes we get the conflicting information from the regulatory bodies or the areas where we get guidance, and it may not be the organization's fault or the leader's fault that there's competing information. And I feel like the ever-changing environment during COVID times, which is really the meat and potatoes of this conversation, that happened frequently for people. And what an attack on the culture, regardless of how many passionate people you have. One thing I know about passionate people is they want to make sure that they're doing the right thing. And when they feel like they're switching gears all the time, it can feel really uncomfortable. And sometimes it can turn that passion into a real struggle because of the internal conflict that ensues. Can you talk about not only that challenge, but also having that new staff that don't have all the experience to sit on, to prop them up during that experience? Can you talk about what that was like? And then we can dive into the more practical aspects of that discussion.
Yeah. Gosh, one of the hardest things that happened during this was keeping up with all of the guidance that was coming down and what the source was, and deciding what the source of truth we were going to follow as an organization. So we actually internally with our leadership team developed here are our sources of truth and what we're going to follow. And we did it hierarchical. So obviously we've got to keep our doors open. So the ones that are regulatory, that was we've got to be within regulatory standards. And then looking at what are the recommendations that are coming out from different organizations, professional organizations. Are they different than the regulatory standards? And synthesizing those into what is going to be our standard as an organization, and then how do we communicate out how we came to that decision. And there were days we did better than other days. There were days where I would just felt like, gosh, we nailed it with the communication and everybody's on the same page and we're headed forward. And then there were some days where my phone was ringing off the hook because the way that we had communicated it down just caused more challenges. So one of the things for us as Peace Health Incident Command was being really nimble and looking at that guidance and communicating with one voice, and then making sure that the folks who are doing the work understand the why. We have a saying on my team, and I'm sure it's not unique to us, but if they understand the why, they will comply. And so we sought first to say, here is the reason that we're doing this, and then here's how we're going to implement it. And that helped us really communicate with purpose and to get through to our teams what we needed to do. What I will say that was really challenging was we were at a system level developing guidance for 10 hospitals, 150 clinics, and sometimes we wouldn't think of all of the questions, right, that would come up. And so I would go to communicate to my team, okay, here's what we advocated for at System Incident Command. Here's what came out of it. Here's our direction as an organization. And inevitably someone would raise their hand and say, Catherine, did you think about X? And I'm like, well, heck no, I didn't think about X. I don't know why I didn't think about X, but I'm only one person here. So as the pandemic evolved, getting folks from my team at the table where the decisions were being made to hear the why and be able to ping me on the side and say, can we think about this? Can we think about that? And still speaking as one voice from the infection prevention team to our System Incident Command, but having more than my ears at the table.
Yeah, that really goes back to culture. I feel like you're encouraging ownership in a really functional way. And the whole thing about passion, about how it can turn on you and things are getting muddy, that's a great way to navigate that challenge, because instead of people feeling victim to the uncertainty, they become part of the resolution. That's so critical. I want to go back to the standards and the guidelines, specifically around state and federal guidance, because sometimes that's also in conflict. And I feel like COVID headed us down that path as well. Can you talk about getting that married up as a team, speaking from that one voice?
Yeah. What was really challenging for us is we have 10 hospitals across 3 different states, and each of those states had a little bit different guidance. What we found was that our state of Washington guidance tended to be the most conservative guidance, and even sometimes more conservative than the federal guidance that was coming out. And so as an organization, we made the decision that because for our electronic medical record, for standards across, for speaking with one voice as an organization, that as much as we could, we would have one standard across the organization. So instead of establishing, well, we're going to follow Oregon's guidance in Oregon, we're going to follow Washington's guidance in Washington, and Alaska's guidance in Alaska, we said, we're going to take the most conservative of all of the guidance from all 3 states, and we're going to follow that as long as it makes sense. And for the most part, that really helped us, because then we were saying, well, gosh, in Oregon, you're only required to do this. However, we're going above and beyond, and selling it as we're going above and beyond to protect you, to protect our patients. And so that it wasn't a like, gosh, this is such a resource waste. That wasn't it at all. And we looked at resources closely to make sure that we were doing the right thing. And it's worked really well for us to have that one voice, because then my team all takes call. and you take call for all 3 states. So you didn't have to remember what's the guidance in Oregon, what's the guidance in Washington, what's the guidance in Alaska. All you had to do was know the Peace Health guidance.
So you had one set of policies and procedures that all 3 different states would follow, and you would use a model where you used, in a sense, the most conservative or worst case scenario, if you will, so that everyone was complying with at least all 3 of those laws, and none of those state laws were being violated in any case. Is that right?
Exactly. And even when it wasn't laws, sometimes it was guidance like what constitutes an exposure to a healthcare worker? What type of contact does that person have to have? And that differed actually even by county in some cases of what the local health jurisdiction. So we pulled all of our local health jurisdictions and said, okay, this is the most conservative definition of exposure. We're going to use that as our standard within Peace Health.
Okay, so let's see if we can go into an example here. Let's say, for example, one of those states within Peace Health had a law that said you only had to track and report to the state Department of Health pursuant to the state legislature's laws. You only had to report, let's say, an antibiotic-resistant infection. I'm assuming that all 3 or at least one of those 3 states had such a type of regulation or guidance. Is that true?
Around COVID, yes. Which COVID infections were reportable.
Right. So let's talk about superbugs a little bit. Let's say we're talking about an E. coli strain, for example. If we have an E. coli strain that maybe where we've identified an outbreak and maybe with significant morbidity, if even mortality, I'm assuming some of those states within Peace Health would require that those types of infections be tracked and that you then would report them to the state if they adhere to some criteria. Does that make sense? Is that right?
Yeah, that's true. We have infections. All 3 states have laws around what infections are reportable to them. And then every state has the requirement that we practice in that in outbreaks be reported to the state. So, and it doesn't matter. It's any sort of infectious disease outbreak, regardless of drug resistant, not drug resistant virus, has to be reported.
So for some states like Washington State or Rhode Island, I've read some outbreak investigation guidance that says an outbreak can be actually a single case of an uncommon or atypical organism, not necessarily 2 or more infections. Is that something that you have come upon? And if you do, I have a follow-up to that.
Yeah, absolutely. So carbapenemase producing carbapenem resistant Enterobacteriaceae, one of those is an outbreak, as would a C. albicans.
So one or more of those 3 states within Peace Health, are they then requiring hospitals to track antibiotic susceptible strains of E. coli that might be readily destroyed? If we have an outbreak of susceptible E. coli, would those states require us to report that to the state, or would it only be antibiotic resistant, say CRE E. coli? Or did you say that hospitals within the Peace Health systems have to track both types and report the susceptible and the resistant types to the hospital? Is that correct? To the state, is that correct?
Yeah, that's correct. An outbreak, regardless of what the organism is or its susceptibility, is reportable in Oregon, Alaska, and Washington. You don't find outbreaks unless you look for them. And so if your head is buried in the sand, and then of course you don't have an outbreak. The important thing with epidemiology is you've got to know what your definition is, and then you've got to be able to track and find that. So there are so many ways that you find outbreaks. The lab is one of your key partners. Anytime I go into a new organization, there are a few people that I make sure that I make friends with, and my lab director is absolutely one, especially anyone in the micro lab. I want to bring them snacks, be their best friend, because they're the ones who are like, hey, yesterday I saw a bug with this same susceptibility pattern come through from the same unit. I just wanted to give you a heads up. Maybe they're unrelated, maybe they're not. So you pick it up from your laboratory, but you also pick it up from someone on the front line who says, gosh, I think these two patients have a similar rash or something like that that's happening. Can you come help me out? And that's really where everyone's an infection preventionist. You need everyone in healthcare to think of themselves as being able to pick up the phone and wave that flag to say, can you come in and help me as the expert look into this further?
Wow, fascinating.
It makes me think about being a mandatory reporter. Like if you perform a certain role in healthcare and you have certain contact with patients, you become a mandatory reporter. I realize it's not the same thing, but it's very similar because the whole point is to get that information so that you can be as preventive as possible.
One year during Infection Prevention Week, I went around with my magic wand and I donned people infection preventionists who were outside of infection prevention. And my whole goal was saying, I'm here, I have a set of expertise, and I have the time to look in and figure this out. I can't do my job if you don't pick up the phone and call me or think of yourself as that way. And you also have a voice to say, gosh, time out. You didn't wash your hands. Just a reminder, a friendly reminder for that. Everyone has to feel empowered to do that work. And it's not, no one should call infection prevention and say, hey, I just saw Dr. So-and-so walk out of a room and they didn't do hand hygiene. Will you call and talk to them? Because that means you've got a culture problem at your hospital. If your frontline staff don't feel comfortable talking to each other about doing hand hygiene or about doing the right thing for patients. So in that same way, you don everyone an infection preventionist, and that's how you pick up those infections. If you don't have the type of culture in your hospital where your lab will pick up the phone, where your frontline staff will pick up the phone, where your clinic staff will pick up the phone and say, hey, I just saw this weird rash. It could be measles. Then you're going to be missing the boat and catching that outbreak as that curve is skyrocketing instead of helping to temper that curve.
So, Catherine, what about the inevitable elephant in the room? Let's say, for example, we have a hospital with this amazing culture that you're describing where we have communication and people are saying, that other patient I saw over there has something kind of like maybe a MRSA or some type of a rash. It looks like patient B and it looks similar to patient A. Gosh, we could have an outbreak there. And there we need to do a root cause investigation and find out. But there's also this saying that what you don't look at and what you don't know about, you can't be held responsible for. So if we really have a hospital that is really being so diligent, isn't it in a sense kind of putting itself in a litigious potentially situation? Because for every outbreak it's identifying, there could be a lapse or a gap that could be causing that then could be used against the hospital. How do we deal with this tension between wanting everyone to be safe, wanting to investigate every outbreak, but realizing there's a real world out there where some of these people who are getting infected may then get discharged and call an attorney, and then the hospital who's doing so well and such a diligent job, this is actually going to be potentially used against them. What are your thoughts on that?
So the evidence is really good that patients respond in a collaborative, non-litigious way if you are open and honest with them.
And transparent. Excellent.
If you say, we screwed up, here's what happened, here's all the investigation that we did, and here's how we're fixing it for the future.
And we're on your side.
We're on your side. We hear you and we want you to be safe and we are sorry. That's what patients want to hear. They want to hear, I'm sorry. They want to hear, we understand there was a problem. We found why there was a problem and we fixed it.
And you've seen that in the real world. You haven't just, I've read that in papers and have just wondered. You've actually seen that in the real world play out.
I have seen that in the real world with patients with outbreaks, as we call and tell them. And over and over again during COVID, we would call our patients and say, gosh, I am so sorry, but a healthcare worker who worked while unknowingly contagious exposed you to COVID. We are sorry. Here's what we're doing to fix it. Here's the site that you can go to get tested. And here are the next steps. And those patients responded incredibly to that.
Wow, that's amazing.
I love that level of accountability too, though.
I do too.
There's a real calling into question just based on symptomology and when they get tested and everything else. And you could have been following a completely reasonable protocol and still have exposed somebody, and you still took accountability for how the patient might feel about that and the fact that it might have put them at risk. That was a really important message that you laid out there that way. And you didn't make an excuse walking into it. Hey, we did everything that we could and we're sorry. And it just doesn't resonate the same way as it doesn't even matter that we did everything that we could. This still happened. And so we're just owning it. And this is what we're going to do. I really love that. And it's a really hard place to get to for a lot of people.
We are so fortunate that our infection prevention team and our risk management team and our patient safety team, we've got those three teams so aligned that when we have an exposure, whether it's COVID, whether it's tuberculosis, whether it's influenza, that we have it dialed in of how we identify which patients were involved and which healthcare workers are involved, that we get those notifications efficiently. And if there's treatment available, we get that treatment. If there's testing that can be done, or if it's just like, hey, an unsterile instrument may have reached you during your procedure. Here's the why. Here's what we're doing to follow up. And we wanted you to know because it was unexpected. So if you don't get the expected treatment, our expectation is that we're notifying you.
Well, as opposed to a hospital maybe saying, look, it happened, but you did sign this informed consent form that said infection is a risk.
That is not how we approach things in Peace Health. Our culture is that we know that errors happen in healthcare and we're always driving towards zero. And if we don't talk about why it happened and lay out steps to prevent it from happening in the future, we can't get to zero. And that comes all the way from our system board of directors down. That accountability for driving that with the patients. And so that makes my job easier because I'm not the one saying to our system board of directors, I need your help making this important. They make it important and make it my job and my colleagues' job to implement that.
And how do you do then with regard to the reimbursement and the payments? I'm thinking that your hospital doesn't generally get fined and you don't get, and Medicare does not, in terms of hospital acquired conditions and readmissions, I'm assuming that you're doing pretty well on that and haven't run into a lot of problems and probably maybe have never even been fined?
Well, the way that funding works, part of your Medicare, Medicaid money is held back, and then you have to earn that back based on your hospital acquired conditions, based on your patient satisfaction. And so our goal is always to earn back all of that money and hopefully to earn back some of someone else's money that isn't working as hard and having as good of outcomes. There are some challenges with that value-based care and purchasing, the way that works, but it is one way that healthcare is held accountable. And certainly when we're looking at that, we want to earn all of those dollars back.
All right, Catherine, this has really been an amazing interview. And I still had a few other questions that we didn't even get to, but I really like where we went with the conversation. And I do have to commend you that everything in this conversation tied back to culture, but in very practical ways. In specific ways to achieve a healthy and positive culture. I know you're a big part of that. I know there's lots of other people, not only on the leadership team, but not in leadership around you that work within the organization that are helping to drive that. But the way that you presented that to us today, and I think there are some people out there that have some real takeaways that they can start putting into place after they listen to this interview. So thanks so much for being so open with us during this discussion.
Yeah, I really appreciate the opportunity. And what I want to say to infection preventionists out there or people who are aspiring infection preventionists, if you're not coming to work for me, come to work for an organization that believes in that transparency and that culture and puts that into practice, because that's what's going to make or break your career in infection prevention. If you feel like you're constantly fighting against the leaders in your organization to get infection prevention to be a top priority, you're not in the right organization. And I can promise you that there are organizations who do prioritize that, and we're always looking for good people to join our teams.
That was Catherine Kroll, System Director for Infection Prevention at Peace Health. And Larry, she told us very early on that she's always recruiting, and she wrapped up that interview with a recruiting message out there. And honestly, though, inspiring. Anytime you work for an organization, you want to know that you're in alignment from top to bottom and that the mission that you have every day when you go to work, and it definitely helps how you feel intrinsically. I also really enjoyed the conversation that you had, getting into the weeds a little bit around state and federal guidance and how to navigate all that. And then I was completely unaware until you brought it up that some states require you to report susceptibility and then others do not. And that's very interesting. We're only as good as the data that we have to work with.
Right. There's this debate that's been going on between whether healthcare in America, or public health specifically in America, should be on a state by state or even local district basis, or whether there should be standardization and things should be on a more national basis. I think both are appropriate. I think when it comes to outbreaks, for example, what's going on in one particular locale or district, on the East Coast isn't necessarily at all germane to the precautions you would adopt on the West Coast. So we have this disparity around the country that is causing a lot of confusion. And I think we certainly saw it play out with regard to COVID and masking and vaccination and all that. So in some ways, we need to talk more about what we can standardize nationally and what maybe is appropriate to keep on a local basis.
Great conversation with Catherine today. And as we wrap up, I do want to remind everybody the best way to listen to the Transmission Control podcast is by downloading our smartphone app for iPhone or Android. We'll have bonus content for some episodes. And if you're already listening on Google, Amazon, or Apple Podcasts, you'll find us there, as well as Stitcher, iHeartRadio, and Spotify. And honestly, if you've got a favorite podcast application, just search for the Transmission Control podcast and you'll find us there. And if you're listening and you like what you hear, make sure you give us a rating and a review because we love feedback. You can send us an email as well with how you feel about the show, maybe some future topics or guests. Just send it to info@transmissioncontrolmedia.com. On behalf of Larry and myself, thanks for listening to this episode of Transmission Control.